What I'm going to present to you today is sort of the role of the patient-centered medical home in asthma care and how it ties into all the work all of us and my colleagues on the panel are doing in the community and in schools. And just to give a very simplified definition, the patient-centered medical home really is a health home. If you kind of think back to maybe when you were young or your parents were young, sort of the family doctor who knew everybody. I had the luxury of growing up with a father who was a pediatrician in an urban inner city area who knew everybody in town and everybody knew him and he was the doctor. And it's interesting to me that we're sort of trying to create that nationally now with what's called patient-centered medical homes. And it doesn't have to be a clinic, it can be a private practice. And we'll talk a little bit more about that. My presentation today is a very quick overview of a longer presentation that's an hour or an hour and a half that my organization, which represents clinicians who work with low-income communities, put together for continuing medical education credit. So if somebody wants to know more about that or wants us to come to your community to present that, feel free to grab me afterwards. We can talk about that. I think we're all here because we know that when you're a kid or an adult and you can't breathe, it doesn't matter what you're having for dinner. It doesn't matter that your homework is due tomorrow. Nothing else matters. So I want to just tell you the story of a little girl named Rosita, who is very much like the patients that I see every day. And I don't need, since this is an asthma group, I don't need to hit you over the head with all the statistics as people who don't know about asthma might need to hear. But she's a kid who's been misdiagnosed. She's been diagnosed with reactive airway disease. She lives in a place with poor housing with a lot of the asthma triggers that we've heard about today. Her mom can't always afford the medications, doesn't understand when she gets prescriptions which ones she should buy, which ones maybe she shouldn't buy. Her mom really hasn't known where to take her for health care. Her mom has what we call low health literacy, doesn't really understand the difference between the albuterol inhaler and the steroid inhaler. Her mom also doesn't speak English as a first language, so a lot of the information has been given to her in a language she doesn't understand. And she has the cultural belief that you grow out of asthma. She also came from Latin America where she had dirt floors, and so when people have talked to her about asthma trigger management and ripping up the carpet, she doesn't really want to rip up the carpet because she feels that it's a privilege to live here and have a carpet. And the kind of things that we talk about in our training and that I want to talk about today are how the patient-centered medical home can deal with some of these things that Rosita is facing. Her mother found her many times coughing, wheezing, showing traditional signs of asthma, and brought her to an urgent care center in their local community. Then a different time brought her to a Target clinic where she saw a provider. Then one time brought her to the emergency room because it was 3 o'clock in the morning. And each time she went, she got different treatments, nebulizers, a steroid injection, but every time she was told to go follow up with her provider and given a bunch of prescriptions that she could not fill, and because she couldn't afford it. As I mentioned, her mother came from Latin America. She works at nights, often leaves Rosita at home with an uncle who smokes in the house. And she's also very concerned about the brother who's been having some ADHD problems in the school. And so dealing with Rosita's asthma and the fact that sometimes Rosita can't breathe is just one more stressor for her. And as I mentioned, every time she goes to one of these places to get care for her daughter's asthma, she's given information in a language that she doesn't understand. She's one of 55 million people in the United States that doesn't speak English at home, but she doesn't want to say that she doesn't understand, and she uses her broken English and says, yes, 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 that she'll do all this. So Rosita's not getting better, and fortunately Rosita is involved in her school and is enrolled in a good school, and the school nurse understands all these limitations and says, look, you can go to the local community health clinic, and even if you're uninsured, and I like to say many of these kids are uninsurable because if they weren't born here, they don't have access to insurance, they will see you. Any federally qualified health center is required to see people who have no insurance, as well as those on Medicaid. And in the medical home that we're talking about, they try, hopefully, in the best case scenario, they try to make access for patients more available. So it's not like, yes, we have an appointment next Thursday or July 26th. If you're having an asthma attack, you want an appointment now. So many times the patient-centered medical home will have what they call open access or same-day appointments. In some places, even patients can self-schedule online. the patient-centered medical home can help with the medication management. Where I work, we have nurses and other folks who will help you fill out the patient assistance forms. And there's so many levels of that that's complicated, including the literacy. But one of the things that's really complicated is if you need an asthma inhaler, this is not the kind of thing you can write away for and do all the paperwork and send in your taxes and you get it back in 6 weeks and then you'll be fine. So there needs to be a system set up where you kind of have a, let's use the one on the shelf and order another one to replace that one on the shelf. So that takes a little clinic ingenuity to make that happen. Because most community health clinics are moving towards electronic health records, there's patient tracking. One of the things I just heard about at an EPA conference last week was a clinic that had asthma flu shot day, and they can pull up all their asthmatics because it's tracked in an electronic health record. I know that in the old day we used to flag the charts with a certain color, who had this or who had that, and then when HIV came around, you weren't allowed to put a little red dot on those who were HIV positive because that was not cool. But frankly, with an electronic health record, you can pull up all of your persistent asthma patients, so know your asthma patients under 10 and do flu shot day for them and have a clown, and then for your patients who are teenagers, do flu shot day for them and have something that may be more appropriate for teenagers. So those are the kind of things that you may find in a medical home. Any place that receives federal funds needs to have medical interpreters, needs to abide by the Civil Rights Act and have people who can speak the language of the patients. So communication can be better, and hopefully health literacy will be dealt better. And so we look at the patient-centered medical home. It can provide a lot of these links for patients that they need so that the providers in the 15 minutes you have with the patient can focus on the National Heart, Lung, and Blood Guidelines that talk about all the things that we need to do, assess asthma severity, asthma control, prescribe a steroid. I think one of the things that's really important to point out, and people often don't know this because one of the questions we always ask is the government put out these great guidelines on asthma, and the studies show that this is how asthma should be treated, and we want to know, well, why aren't we doing this? And the fact of the matter that I've seen is a lot of providers just don't know what the guidelines are. But now, to be a patient-centered medical home, you have to get certain benchmarks. And again, with the electronic health record, you can pull it up and look at how your providers are doing. And one of the things that got thrown at me in my clinic this morning was my quarterly peer review, where I have to review the charts of other clinicians. But that's where I can say, you're not doing this for your asthmatics or your diabetics. And so many things that are included in the guidelines on care of asthma are ways, I think, that we can get the providers, if you have a unified health system in an electronic health record, to make sure that we're doing what we're supposed to be doing, including all of the things that were the priority messages from those guidelines. Assessing severity. I mean, every time I see a chart and somebody says asthma, I say, is it mild, intermittent, or is it severe, persistent, or somewhere in between? And more with a patient-centered medical home, we're going to be forced as clinicians to come up with that, and that's important to have that diagnosis, and then obviously to go through the steps to do the right prescribing. They want to know through the electronic medical record, does everybody have an asthma action plan? In a good electronic health record, you can print it out in the language, in the target language of your population. I'm having a little trouble with that. We got the French, we got the Spanish. We live in such a multicultural environment. I still can't print it out in other languages. Again, just like our colleagues here have our 5, 2-minute, 10-minute warning, whatever, with the stoplight. The stoplight is something that is so well understood by patients, even patients who don't read very well. And we'll hear soon from somebody on my panel who's a school health nurse, but I make sure they get 2 copies of this all the time, and I always fold one up and put it in an envelope and say, this is for your school nurse. And I've been around long enough that I usually know, well, if it's Eastern Middle School, that goes to Megan, and if it's Harmony Hills, that goes to Annie. And I know who the school nurses are, and then I put a little note on it. Hi, Annie, hope this kid is doing okay at school. Just to get that personal touch, because the school nurses are with the kids day in and day out. And in a good case, with a well-controlled asthmatic kid, I'm seeing him once, maybe twice a year. I'm happy if I don't see him very much. And so I really want to make sure that I can communicate with the school nurses. We talk a lot in asthma about self-management, and and what people can do for themselves. And there's only so much that I can do and the teaching that I can do. And I find that giving people self-management tools that have pictures where they can fill it in themselves. And I even get kids, 6 or 8 years old, taking these and filling them in themselves so they can mark down how well their asthma is and bringing them back, something that I find very helpful. I mentioned the issue of the making sure that people are on inhaled corticosteroids, and the point I wanted to make about this was that just in case people don't know, and I'm trying to remember the number, I didn't write it down, but the cheapest steroid inhaler, if you're uninsured, is pretty sure it's $114, and that's Qvar. And I'm not saying we shouldn't prescribe that. Obviously, I think we should. But often for kids, we need to figure out how they can access it. And I've seen tons of stuff in the community, like, let's get stuffed animals for all the kids and give them away at Christmas. I mean, my local fire department does that. That is really great, but we know as asthma educators that the more stuffed animals, the more dust mites, the more asthma. And, a stuffed animal may be $3 or $5, and an inhaler is $100. But we really need to look outside the clinic situation. When people say, what can I do for your clinic? I always say, donate money for the inhalers, and so somebody can get a voucher. And then we set up a relationship with a local pharmacy. I have to say, it used to be easier before CVS and Walgreens and all these places came into being, and there was no local pharmacist that you could talk to anymore. I did develop a relationship with a pharmacist at a Shoppers Food Warehouse who knows me, and so we get people to donate to that pharmacy. And I didn't have such luck with the CVS and the Walgreens because they're too big of a system. But we also really look at the healthcare team as a whole, and if there is an in-house pharmacist, or even if there isn't, there's a pharmacist in the community, making sure that they are providing some of the medication management. I think, as you all know way too well, what happens often is that so we get people to donate to that pharmacy. And I didn't have such luck with the CVS and the Walgreens because they're too big of a system. But we also really look at the healthcare team as a whole, and if there is an in-house pharmacist, or even if there isn't, there's a pharmacist in the community, making sure that they are providing some of the medication management. I think, as you all know way too well, what happens often is that people want to refill on their albuterol inhaler all the time, and they seem to not be using their steroid. Then there's a lot of myths around that, and my kid won't grow, or steroids are bad, or he won't be able to play sports because they'll do a blood test, and then he won't make it into the Olympics because he's on steroids, and all sorts of myths that need to be discussed. But the pharmacists often are the ones who know who's refilling what and when. So making that contact with the pharmacy and relying on your pharmacist to provide some of that education, again, especially from a culturally and linguistic point of view. The pharmacist that I mentioned that I developed a relationship with is Ethiopian and speaks Amharic. I don't speak Amharic, and so I just say to all my patients with asthma, go over there and talk to him, and he'll explain to you how to use the inhaler, because I can explain, but I would rather have him explain if he speaks it in their language. Other things that we look in a patient-centered medical home, group visits. There's a lot of discussion around coding for group visits. The way a lot of places have worked it out, you bring in all your asthmatics, they spend time with a nurse or an asthma educator, and one by one they kind of peel off from the group. Somebody listens to their lungs, hopefully they're doing okay, refills the meds, and that will take me 5 minutes to do, and I can code for that visit, where they're spending an hour with a group in a group visit talking about asthma. And often the parents, I think, learn just as much from the other parents as they do from the experts who come. I know I've done that with Lois in Montgomery County with some of the Hispanic parents, and what's as enjoyable to them as hearing from the quote-unquote experts is being with other families and talking about asthma and getting that group support. Asthma home visits, it's a luxury that some places have. Some of the schools have the nurses going home, like the Head Start programs do a home visit, but that's really where you can see the triggers that are in the home. I think home visits are fabulous. I wish we could get better reimbursement for that. And then, sort of looking outside the box for education, puppets. Remember I talked about bringing everybody in for an asthma day, or bringing everybody in for their flu shots. Can we do skits, puppet shows, songs, have them write their songs? Allergy and Asthma Foundation Mothers of America. They're based in Northern Virginia. They're having a contest to see who can come up with the best name for some kind of asthma inhaler. They want kids to do a drawing of, what they would like to see in an asthma inhaler. So involving the children themselves. It just drives me nuts when people give out information in a language people don't understand or in a way people don't understand. And oftentimes, I admit it's not the providers who know this, it's more the